Okay, so we'll take some comments from the audience on any or all of this or other ideas, things that you think may have been overstated or understated. That would be good to hear. But let me push a little bit with Steve and Dr. Bronstein on the issue of signals and follow-up. I'm just asking whether, Steve, you could state a little more specifically what hypothesis do you think is being tested here exactly? What signal is being followed up on? I know we listened to your talk, but I'd like to get a sort of a very specific notion of, because you called for actually a cohort and some kind of longitudinal follow-up, I think, not just a registry. I think Dr. Bronstein was talking about a registry, which would help define whether there's an acute effect. But maybe I could ask each of you to just clarify a little bit on those points.
Well, thank you. And I think they are very different types of research. You know, mentioned earlier, for more than 2 decades, I've been PI of the NHLBI Pediatric Cardiomyopathy Registry, where we started that because nobody knew how to really get to better outcomes over 40 years for kids with cardiomyopathies. No one center saw enough. We weren't really consistent. And we got 250 centers all through North America together. When we got 40,000 annual forms, we could actually start publishing an awful lot of papers in terms of not necessarily what were the hypotheses we had going into it, but then understanding what the course was for these patients. We could then look and see, as I was getting at, other things such as risk factors and other exposures that might contribute and the like. And it's served as a very useful platform. In conjunction with that registry, NHLBI along the way decided to fund a biologic specimen repository. Well, why was that important? Because as we started to understand the course, and we saw that certain groups had very different outcomes after exposure than others, we then said, well, is there genetic susceptibility? We had a paper just this month where we had 9-fold increased rate of dead heart muscle and with certain exposures. Well, you can pick up a priority for that exposure. That was important, but if you didn't have the concurrent biologic specimen repository, you would have not been able to necessarily do that. You can say, well, you can always go back, but if a group has had events along the way and they're no longer there, you lose that opportunity and you get LTF issues of loss to follow. And then, so registries are important to, if you can really have good tracking with little missing data, to really ascertain what the course is and are there safety signals and are there a variety of hypotheses. At this meeting, I could give you 50 different hypotheses, all equally interesting, that one would be interested in looking at with a well-characterized population. Now, the other thing, that I was bringing up was a longitudinal cohort study with a defined number of patients, more hypothesis-driven, and more limited in scope, and with really select inclusion-exclusion criteria. It's a different approach. It's what you do when you think you really do have a safety signal. You really do want to test it, and here, leaving this meeting, because of the presentations, because of the discussion, it's not that we have consensus that there's absolutely no safety concerns associated with these products. Your degree of concern varies based on who you are in this room, but there still are concerns. And so in that setting, to me, next steps, whether you go in a registry, where again, it's possible. This is what CDC does a lot when they really go out and they really ascertain, or you use a platform such as NPDS or something else. But again, that's picking up ones that come to attention. If you're really trying to say, let's have a cohort that, we're going to have them starting out with no exposure. They're then going to have exposure. We're going to look at dose. We're going to look at chronicity. We're going to look at risk factors. That really lends itself more to a prospective cohort type study. So it depends on what the issues are, but they're both potentially very valuable designs. And if you go one way or the other, 5 years from now, you're going to be in a much better position to answer a lot of these questions and not say, oh my gosh, haven't we done caffeine twice before or 3 times before or 10 times before? We might actually have an informative cohort to try to answer some of the 2013 questions and some of the ones that may emerge by 2018 that we can't even answer now, but we've characterized these patients.
Well, I can understand how a good registry might help on the question of whether caffeine-containing beverages are causally linked to these outcomes. But I'm not sure I understand exactly how, would it help answer the question of whether the drinks are related to these outcomes, a longitudinal study?
A longitudinal study,
You're not talking about,
especially if you target certain a priori groups that you think may be at higher risk, gives you the opportunity more at a subclinical level with real biomarkers, whether they're genetic, whether they're physiologic, whether they're biochemical, to see what are changes, what associates in a significant way or not. You're probably not going to be powered with resources available to do one against what frequently FDA for a indication asks for, and that are hard endpoints, because you'll have far too limited unless they're really high-risk patients. But if you say, are there really subclinical differences that occur, some of which may be viewed in an adverse way, and you want to make the case, as was being brought up by Megan, are these combinations, or those, are there differences or not? It gives you an opportunity with more power to answer the question, having a number of subclinical things that you've ascertained.
Let me just ask, I'll turn it over, I'll shut up in a minute, but let me just ask Dr. Bronstein on you are recommending a registry. Do you think there's enough of a signal with caffeine-containing beverages to call for a registry? And would that answer the question about, with reasonable certainty, about causal relationships?
I was not recommending a registry per se. Let me give you an example of some of the things we've done. There was a product called Total Body Formula, and which had excess honeyum in it. Caused nail changes, caused hair loss. It was removed from the market by FDA. We worked with FDA and CDC for cases that were called to poison centers to find the location of these cases where the public health departments could investigate the people who were reporting symptoms to this product. There were about 160 different cases, as I recall. So this helped to really focus on the issue, help the people who were exposed, and of course, it validated getting the product off the market. So what I'm suggesting is there's a lot of questions about these products. There's a lot of questions about how they're used and questions about if they're mixed with other products. And it's not just these products. There's many product questions about all products that are marketed in the U.S. And so what I'm suggesting that one way to go would be to educate the public that if there are issues that come up, this is a place one could call for not only to report exposures, but to get information. Maybe people should be taught about supplements, proper use. Poison centers, for instance, could be used to disseminate that information. That information obviously people could be referred to the internet sites to get information about proper use of foods and proper nutrition and such, and dietary supplements and these various products that contain caffeine, that contain other things. So that's one possibility. The other thing would be people to report exposures, and we track these exposures and we look for signals, look for cases. If someone has an adverse outcome, and if we know about it quickly, we're able to investigate it. It's not very easy to go back 6 months later and investigate someone who's passed away, for instance, or who had a rash. It's very difficult to get the information. This would also, I think, be helpful if we actually tracked these exposures, which we receive anyway, to know what's going on as a snippet of use in the country, which would give us some comfort that maybe nothing's going on, or we begin to see certain patterns and do it in real time. don't look at it just once a year, but do it on a daily basis or a weekly basis to pick up trends and to be able to marshal public health efforts to investigate cases that meet certain definitions that we define for what's a case of public health significance. That, I think, is one way poison centers and the poison data system and the people who answer the telephones can be used and used now. To me, we do surveillance now, and we look for bad things happening, and things are pretty quiet. And there is value in knowing things are quiet. There's value in knowing something's going on, but there's also great value in knowing nothing's going on. So I'm proposing this is a novel way to take the system that exists, an existing system with its infrastructure, to monitor this issue. It can monitor other issues. This could be a model for the future of how to look at these issues that take many years to write papers about, to do clinical research, et cetera. So that's what I'm suggesting.
Okay, thank you. That's clear to me. Let me ask Lynn. You've been standing there a while. Then we'll see if other panelists have any comments on this or anything else.
Yeah, just a couple of comments and then I actually have a question. And what Dr. Bronstein is suggesting, a lot of people for many years have felt that the poison reporting system surveillance part of it could be improved in general by having a more complete kind of case follow-up, not just for caffeine-related and energy drink-related calls, but all kinds of issues that come their way that are never followed up. And there are a lot of data that I've seen over the years, a lot like the data that we saw presented here, where it's difficult to interpret what the data mean because of not having adequate information about the exposures and the outcomes and follow-up and so forth. The other point I wanted to make briefly is that in terms of the sudden cardiac death among youth and near-miss episodes, that does remind me of the problem that we have with birth defects and also pediatric cancers, which are both very rare and that we cannot identify in the longitudinal cohort studies, and where registries have indeed been very useful in terms of providing large enough numbers of cases to do proper studies. And so it just seems to me that maybe it is a birth defect, actually, when I think about it. But I wanted to ask a question that's really goes back to actually what Mark Feely presented, and Joe, you alluded to it. And as we have all these uncertainties about the science and that need to be evaluated, and then we heard that Health Canada has taken what seems to me to be kind of a simple approach to say moderate caffeine consumption, 400 milligrams a day in healthy people seems safe. Advise people that's okay. Pregnancy may be a little bit riskier. Advise people to limit themselves to 300 milligrams instead of 400. And Mark, correct me if I'm interpreting this wrong. And that pediatric aspects need to consider that children are smaller, so they seem to have developed a 2.5 milligrams per kilogram recommendation for children under 12, and then it seems to me it's a suggestion of 2.5 milligrams per kilogram for children above the age of 12. It's the same amount, maybe in a way kind of pragmatic, but I've just, in terms of what we know and what we don't know, how the panel responds to that kind of an approach to trying to determine safe levels, and whether there's research that could help to inform that.
Thank you, Lynn, for that question. And those values relate to chronic intake, I assume, yes? They have nothing to do with the issue of, Mark, is that correct?
It's supposedly intake at any point in time, but for the reproductive effects, they would be more related to chronic exposure, whereas the infant effects are more acute exposure.
Acute exposure, okay. So any thoughts on these levels?
Yeah, I think those are based on best available data for population. I think part of what I was trying to bring up in my talk, that although population data is important, and population recommendations are important. For specific vulnerable groups, whether it's proven or just of concern by clinicians, those may not be the appropriate approach whatsoever. And in terms of giving a false sense of security or this is safe without doing the data is doing nobody a service. I think that if you identify certain potentially vulnerable populations, part of what we usually do is we try to study to determine really what is safe in those subpopulations, and at the same time, if there's no real therapeutic efficacy, we try to avoid that exposure. And there's plenty of examples, at least with children, where that's the approach we take. So just saying across the board, there's one standard for all, actually does a disservice for those potentially at highest risk. What you have no idea right now is of the groups that have.
Just to be clear, it's not one standard. I mean, it's different for children and for women of childbearing age.
Completely agree. But amongst children, what I was saying is if I have a child that has heart failure, cardiomyopathy, and arrhythmias, is the standard for children going to be appropriate? I bet you would find almost no pediatric cardiologist that would buy into that concept. And I think that's where, again, it gives, a lot of times, at least for our national organizations, we're required to put levels of evidence next to guidelines or recommendations. There's zero level of evidence that for certain subpopulations here that would be a safe threshold. And I think that one has to be careful when you think about population versus potential vulnerable population. If you think that there are vulnerable populations, it behooves you to then either protect them or test it or do both. But to just say that a certain threshold defines safety, it's not a service.
Let me just ask if other panelists have a comment on what Dr. Goldman asked.
I agree with Steve's comments. I think that that gets into the risk management part of this discussion, and I think we were more prepared to stay on the risk assessment side. But I think that one of the things you have to realize is that to really be a responsible public health professional, you have to understand that people will do things other than what you intended them to do with a recommendation. So I think a recommendation is probably the weakest public health response you can make. I think you have to be stronger in your response if you're going to get into the risk management issue to limit concentration and dose of what is available.
I agree totally that I think a recommendation for women of reproductive age is translated to most women as I'm of reproductive age when I find out I'm pregnant, and then then it applies. And so then you're into the situation where the risk management for that individual may be based on a guideline that is so conservative that the message to the woman is that I'm at increased risk for all of these adverse outcomes because I was consuming 350 milligrams a day of caffeine. So the evidence needs to be there to be able to support that. That being said, an individual's risk for having a baby that's 50 grams lighter, if there's evidence to support that, may not be very important for that individual or healthcare provider, but if 50% of the population is using a product that reduces the mean birth weight by 50 grams, maybe that is important. So I think the evidence needs to be there to support that.
Dr. Schaefer, I think you had a comment.
Yeah, I think that one of the problems is the science isn't there. And, you can have a person dying of sudden death or develop arrhythmias, and you go back in history and say, okay, he had consumed some energy drinks, but there's no studies where one sets up a group of patients and does a double-blind randomized study with various concentrations of energy drinks or caffeine or whatever you want, and then looks at the endpoint, and that's the problem. And until you define clearly what vulnerable groups are and under what conditions, then I think it's very difficult to make recommendations.
Amelia wants to
Just
follow up quickly.
one quick
Okay.
comment. There's, I agree that if we had the ability to do those randomized controlled trials, that would answer the question if we followed them over time with different patterns of consumption. One of the problems we're going to have in doing that is ethical concerns from IRBs to administer doses that are similar to the natural doses that are consumed in the population, especially the doses that I'll take responsibility that I see among adolescents and young adults consuming. I don't think you could get it through an IRB to randomly assign children and adolescents and even young adults to high doses of caffeine that is consumed naturally. You can't even get them above 0.08 for alcohol studies. And you know that kids drink above 0.08. The study design that Steve was suggesting is a naturalistic cohort study where you can measure natural levels of consumption, where you don't necessarily give them or administer that high dose, but you watch what happens when people consume in that high range. And you can do it with oversampling. You can oversample for high frequency energy drink users to increase your power. There's a lot of ways of doing it. I just wanted to point out the difference between experimental randomized controlled designs and longitudinal prospective cohort studies and the advantages and disadvantages of both.
Let me just comment though, Dr. Schaefer, so the Canadian values, as I understand them, and I've looked at their documentation, is based on a very, very large number of studies. So what is missing in their values for general population and
I think it's on caffeine. I don't think that he commented on energy drink consumption.
Is that what you meant, Dr. Schaefer, when you said there's inadequate data? Were you commenting on these values?
There's been a lot of talk about vulnerable groups, and one has not, based on scientific evidence, defined exactly what that vulnerable group is. And I think that more studies need to be done, and carefully controlled studies need to be done to define what a vulnerable group is, if there is in fact a vulnerable group, and under what conditions are they vulnerable.
Okay, let's go to the audience for some questions or comments. Dr. Higgins?
Dr. John Higgins, UT Health, Memorial Hermann Harris Health. I'd just like to agree with the panelists, their evaluation. I think Steve summed it up really well, that there are some signals that we are hearing, and we don't know. I mean, some people see these signals, like Steve and I, and other physicians who are here have not seen these signals in their emergency rooms and hospitals. So, but the thing is, what we need to do, I believe, is to, because we have seen these signals now, not ignore them, but at least just find out a little bit more. Are they real? Are they some artifact of, or some are being confounded by some other issues in these groups? But so I applaud the panelists for asking. I think we need to do more research, and specifically research on these particular beverages, because the signals we're hearing are from these beverages, not from caffeine, not from coffee, pure caffeine or coffee. So, but in order to do what we're talking about doing, it's going to be tough. It's going to take time. And I think we're all looking to figure out this jigsaw puzzle. Now, I know there are representatives from, I've already met some, from Monster, Red Bull here in the audience, and probably others. And my question is actually to them, and I'd like them to please come up and comment. We know you have very good data on marketing of your products. That is, these 20 million or how many cans, who's consuming them. You know that much better than us. That would help us understand our exposure, who is actually being exposed. And secondly, I know that you guys have done studies, some of which are published, but you have a lot of really good data on consumption and effects of these energy beverages on your study, on people that you've tested, through your companies. So would you be willing to step up and help us out in the meantime? Because, this is something I think we all agree is an important aspect, and we need to get to the bottom of this as soon as possible. And I'm asking the companies who are here, would you be prepared to help us out in this regard? And I'd call on some of the representatives from the companies who are here to please respond.
What-
Oh, it's Bob Arnott here from Monster. Sure. So first of all, in terms of children, when the very first Monster can rolled off the assembly line, however far back then, the company decided they were not going to market to children. They looked at the data. They said there just isn't enough data. We don't feel comfortable. And on the can, since the very first can until today, it has said not recommended for children, not recommended for pregnant women, and not recommended for sensitive populations. Monster is also concerned about the amount of caffeine, and all of the Monster cans now have labeled the amount of caffeine. In terms of adolescents, I think that's where we all agree the contentious issue is. That is, Monster, and I've talked to their, I'm just a consultant, I work for the company, but I've talked to their marketing department. They say, we don't want the adolescents. That is, we don't go to top 40 radio, we don't go to Disney. It would basically cannibalize our market, which is sort of 18 to 34, to go after the adolescent market. So the question is, what do you do? I mean, is there a warning? Is there some kind of proviso for this audience? It's an audience that Monster doesn't sink. I have been impressed with the leadership at Monster that they are looking exactly as you are. They want to know if there, is there something there? They haven't seen anything, but although I can't directly speak for the company, I will certainly speak to them this afternoon about sharing data and working with you to make certain that it's the safest possible product used in the safest possible way. I would point out that when the AMA issued their warning, that they used as their central sort of fact that these energy drinks have 50 times as much caffeine as they have the equivalent caffeine of 50 cups of coffee. I think one of the great surprises about the mainstream energy drinks like Monster is how very little caffeine is in them. That is, if you were to take an 8-ounce serving, that's roughly 80 milligrams of caffeine. 16 is 160 milligrams. If you were to take a Starbucks Grande, that's 320 milligrams. So it has twice the amount of caffeine. On a milligram per ounce basis, it has half the caffeine of coffee. So I would say the companies are very, very interested. They're not trying to obscure. They're not trying to stonewall. They're very interested in this. Clearly, they don't see the same problem as you with 50 billion sold worldwide and 20 billion sold in the United States, and no confirmed deaths. They don't see the same problem. But I was, very impressed with Steve's presentation there. I think a very thoughtful presentation. Obviously concerned about, very sick kids. I think he's done a remarkable job over the years in heartbreaking conditions. These kids with cardiomyopathies and various cardiac disorders. And I totally sympathize with those.
So unless there's a research suggestion here, that response.
Yes,
is
I
very
think. I mean,
fine.
I will.
Okay.
I will bring that to the company this afternoon
Okay.
about potential resources.
Good.
In sharing with you because they genuinely want to know if there's a problem. If there is, what's the most responsible thing to do about it.
Okay, thank you very much. We have some more commenters here. We've got more time.
May I make one comment and follow up to Dr. Arnott's comment at all?
If
Or
it has
should
to
I
do with
hold
the
on?
research idea.
Yeah.
Okay, go ahead. I'm trying to keep the subject research.
Oh, I hear you. So I applaud the idea of going back and trying to partner between industry and FDA and others. About 17 years ago, I was a voting member on the FDA ODAC committee. Herceptin came up. We found terrible cardiac signals, but inadequate data. It left with the recommendation that the company would absolutely participate and absolutely do studies to really get to the answer. Several years later, the black box warning came out, but there was post-marketing surveillance. It was a prescription product, and the safety signals continued. The research that had been promised hadn't been delivered. For children, we've seen a similar number of unanticipated products where FDA, usually with over-the-counter preps over the last 5 years, have had to get involved because of safety signals. But again, even for over-the-counter, there's more of a surveillance system in place. I bring it up because although I applaud industry willingness to at least consider this, I think it's one thing if you have a life-saving medication such as Herceptin, which is what this was. But in this case, without a really life-saving therapeutic reason to take it, and with safety signals in multiple independent databases, I think the issue you brought up earlier about which definition of grass applies, the whole issue of until safety is established, one needs to consider how these really are allowed to move forward.
Let me take comments here from sir.
Thank you very much.
Yes.
My name is Alan Levitin. I'm from Boston Children's Hospital. Excuse me. I wanted to bring up the issue of what additional data need to be collected for one vulnerable population, and that is pregnant women. Things seem to need a little clarification, and I'd like to offer that. Sure, thank you.
Yeah.
Years ago, the contraceptive pill had high doses of estrogen. Women who took that and had been pregnant before said that they felt pregnant. They experienced a pregnancy signal. Many women acknowledge that they may miss one period, but when they're really convinced they're pregnant, they experience that aha moment of a pregnancy signal. And those women here who have been pregnant multiple times will be able to confirm that, I'm sure. One of the early pregnancy signals is an increased sensitivity to the aroma of coffee. And so observational studies have shown that women reduce their coffee consumption involuntarily. They don't intend to reduce it, but they do. It turns out the stronger the pregnancy signal, the more likely they are to reduce their coffee consumption. Ergo, what Dr. Chambers had emphasized, the nausea and vomiting is an indicator of protection against miscarriage. What that really means is that the woman who has a good placenta implantation and allows the placenta to function as a hormone factory, in essence, is the one most likely to experience the pregnancy signal. The woman who is destined to have a miscarriage has a weaker signal. It's as if her placenta is not as well implanted and does not function as well. Ergo, this is a classic example of what epidemiologists call reverse causation. What contributes to the outcome, what contributes to miscarriage, influences the exposure, coffee consumption. I bring that up for spontaneous abortions, and I also ask you to consider that, how that might apply to reduced birth weight. Thank you very much.
Thank you. Dr. Chambers, any comment on that?
I agree
Anything to
totally.
disagree with?
No, I don't disagree, and I think the whole issue of nausea and vomiting of pregnancy and maybe HCG levels should be looked at not just as it relates to spontaneous abortion, but as it relates to preterm birth, reduced birth
I
weight.
think the issue is
Yeah.
that any surveys done, any
Yep,
epidemiologic studies you asked about coffee consumption, ask about
Absolutely.
aversions or pregnancy
Absolutely.
signals.
Avoiding broccoli. Right.
This has been a wonderful discussion.
Could
I'm
you
Johanna Dwyer
introduce
from the
yourself?
Office of Dietary Supplements
Yes.
and Tufts University. My question has to do with the Committee on Military Nutrition here at the Academy, which I believe did at least one and perhaps two or three reports on caffeine over the years. And those are old reports now. But I wondered if, as the committee goes forward, if it'll be looking at some of the data from the military, which I understand is now collecting adverse events, and where consumption of these energy drinks, but also of caffeine, I think is quite high.
Dr. Griffiths? Did anyone want to comment on that?
I don't know of any data collection, but I'll definitely look into it.
There's a fantastic Millennium cohort that's been initiated by the military that's following families who've had an active duty military person, and would be a fantastic way to look at caffeine containing products. It's a good suggestion.
Dr. Griffiths?
Yeah, Roland Griffiths, Johns Hopkins. This has certainly been a fascinating couple of days for me. I wanted just to bring the discussion back to signals and the signal that we, in fact, have produced the most data on, and that's physical dependence. So a lot of these adverse effect signals are really difficult to study. You can't do prospective studies of them ethically for most of them. Happily enough for me, our IRB didn't put constraints of that type on the studies that we've done and other people have done with physical dependence. So these studies have been done prospectively and parametrically, and we've come to know quite a bit about that signal. Now it's not it's certainly not sudden death, but it's not trivial either. So we know with physical dependence that exposure levels of as low as 100 milligrams per day is enough to produce headache. And then it's dose dependent from there. So that really gets me contemplating the question of vulnerable populations and children. And when we start talking about threshold and safe doses for many of these adverse effect signals, it's going to be substantially higher than a couple hundred milligrams. But again, if you're concerned about school-age kids, and being a parent, I am, although my kids have fortunately passed those school-age years. You know, I wouldn't want my kid to be erratically going in and out of caffeine withdrawal and trying to go to school and learn stuff. And so there's some question I have about whether there should be some real thought given to not promoting the consumption of these caffeinated products among school-age kids. Mark Pendergrast wrote a fascinating book called For God, Country, and Coca-Cola, where he went through the whole history of the soft drink industry. And in the course of that, at one point, he says that there was this unspoken rule because there was so much regulatory back and forth between the Coca-Cola and the predecessor agency of the FDA. And he said there was an unspoken rule that the company would never advertise directly for the product to kids. And then somehow that unspoken rule was broken someplace in the 80s, and I don't know the history of that. But I wonder now that we know that this withdrawal signal is there at doses that are relatively low and certainly low enough to be detectable in a single can of many of the energy drinks, whether some further consideration shouldn't be given to restraining the promotion of those products to those kids.
Okay, thank you. We're basically out of time. I don't see anyone else but I give the panelists, if you've got, oh, you want to make one more? Sure.
I just have communicated with the leadership at Monster, and they're happy to dialogue. Delighted to do so. Trade emails, phone numbers right after the conference.
Very efficient, thank you. Any panelists want to take 10 seconds for some final remark that you think you want to make? Maybe not? You've said everything there is to say. Okay. Lynn, do you want to take it from here? Thank you all very, very much for the session.